I'm Dr. Helpman from Gynecology in the Sheba Medical Center, and I'll be talking about advances in the treatment of gynecological cancer and specifically the impact of technology. We'll be talking about four aspects of this: surgical technology, targeted therapies, diagnostic technologies, and digital innovation. We'll start with surgical technology, where certainly the role of technology can be significant. And we know that, say, for ovarian cancer, but we've discovered for other gynecological cancers as well, size really matters. We know that the goal of cytoreductive surgery in this disease, as well as in some others, is no macroscopic residual disease, and that the impact of this is significant, with consistent data in favor of aggressive surgical debulking in ovarian cancer as well as endometrial cancer. Now, does surgical technology play a role in how well we can achieve this goal? Certainly, surgical technologies have pushed the envelope in terms of what we can achieve. At the top, you see things that are in use today, like argon laser, harmonic scalpel, HEPAC sonographic dissectors for liver surgery. But the future might hold others as well. So as Dr. Dotan told you in his preliminary lecture, we're already using virtual reality and augmented reality technologies in the OR in Sheba to reconstruct and superimpose imaging findings on the surgical field. And next steps could be dynamic surgical navigators, sort of GPSs for the surgeon, allowing online in-field guidance for surgeons. So we'll see. Back in 2006, GOG 172 was a clinical trial that showed significant promise for intraperineal chemotherapy in ovarian cancer, demonstrating a 16-month survival benefit, which was unheard of at that time, for optimally cytoreduced advanced ovarian cancer patients with the addition of IP chemotherapy, not intraoperative, but postoperative adjuvant IP chemotherapy. So you're probably familiar with that trial, and that this came after 3 other randomized controlled trials also showed benefits, and that 2 meta-analysis of the data showed a benefit. And the NCI then issued a strong statement in 2006 incorporating this technique in the treatment of ovarian cancer patients with optimally cytoreduced disease, despite worse toxicities and lower completion rates of this treatment. But then GOG 252 and OV 21 both showed disappointing results. With both of them were 3-arm trials looking at over 1,500 participants in the case of GOG 252, and comparing dose dense IV to IP cis, IP carboplatin for ovarian cancer patients, with about an 85% utilization of bevacizumab across all trial arms. And although their overall survival results were impressive, with over 6 years overall survival, they really showed no difference in the 3 trial arms, so no advantage for IP chemotherapy. What about HIPEC? Well, HIPEC in ovarian cancer, until recently, we didn't really have any high quality data on efficacy of HIPEC for ovarian cancer in the primary setting, until this Van Driel study was recently published in the New England Journal. And this looked at interval debulking surgery following 3 cycles of neoadjuvant chemotherapy, incorporating 100 milligrams per meter square intraperitoneal cisplatin administration during optimal cytoreductive surgery in the interval setting, and showed significant progression-free and overall survival benefits, as you can see on the graphs on the right-hand side. Although, surprisingly, it showed a prolonged length of stay for these patients after surgery, but no significant differences in toxicities or quality of life following surgery. So this refuted possible critiques of the role of HIPEC in ovarian cancer surgery, like a delay in these patients for reaching adjuvant treatment because of toxicities. So what about the secondary setting? Well, there we're still a little disappointed because really HIPEC was developed across the board for recurrent metastatic disease in different disease settings, and in ovarian cancer as well. Most observational retrospective data comes from secondary cytoreduction. However, in ovarian cancer, a prospective randomized trial from Memorial Sloan Kettering really showed no advantage to HIPEC in the secondary cytoreduction setting. HIPEC was well tolerated, but did not improve either progression-free or overall survival in this setting. A second technology that I'd like to address is the robotic platform, robotic surgery for gynecological cancers. Certainly, robotic surgery has a role in endometrial cancer, and it can push the envelope and offer minimally invasive surgery to higher risk patients or heavier patients or more complex procedures. What we're really interested in with robotic surgery is its role in ovarian cancer, where open surgery is really the state of the art. And so for ovarian cancer, there's really little high quality data looking at oncological safety of minimally invasive approaches. We do have one single institution study from Montreal, actually, comparing robotic to open interval debulking for ovarian cancer. And that showed longer operative times, low perioperative morbidity for robotic surgery with significantly improved short-term complication rates and comparable oncological outcomes, which was certainly very encouraging. And then we also have a large population-based study from the National Cancer Database showing similar outcomes in this setting and for this disease. So perhaps it will allow us to push that platform for ovarian cancer surgery as well. Right now on the market, we have the intuitive robotic surgery system, which is what we have at Sheba. We have 2 of these systems in our ORs, but there are some competitors in the market, as you can see, which will be coming out in the next 2 or 3 years. And it would be very interesting to see what the future for robotic surgery would look like in the next few years. What about infrared fluorescence technology? Certainly infrared fluorescence has revolutionized the approach to SLN mapping for gynecological malignancies like endometrial cancer, cervical cancer, and vulvar cancer. It allows us mapping and dissection with higher detection rates as compared to older technologies. Competitive technologies are being marketed for this kind of platform and are available for both open, robotic, and laparoscopic surgeries. So a little bit about targeted therapies. Targeted agents have been investigated and adopted over the past decade to supplement the paradigm of surgery and chemotherapy in oncology in general, and in ovarian cancer particularly. For those of you who have heard my opening talks, this is a good time to get that extra cup of coffee because you'll have seen some of these slides. And I will really breeze through them. I talked about VEGF inhibitors and how they really haven't lived up to their promise in terms of improvement in progression-free survival and overall survival for ovarian cancer patients. We talked about PARP inhibitors really being the revolutionary agents in ovarian cancer. So in this disease, PARP inhibition has really pushed the envelope for survival. The way these agents work is through a mechanism called synthetic lethality. So this is where the 2 defects in 2 different genes or 2 different pathways will independently not affect viability of a tumor, but together may be lethal. So in BRCA carriers and in tumors carrying somatic BRCA mutations or other mutations causing homologous recombination defects, the inhibition of PARP enzyme can then cause lethal changes in the cells where the high fidelity homologous recombination pathway is also out of work. And we know that 50% of high-grade serous ovarian cancer patients will have some sort of homologous recombination defect. So this means that PARP inhibitors may be a good answer in about 50% of these patients. So currently in ovarian cancer treatment, both in first line and in recurrent platinum-sensitive disease. There's a host of PARP inhibitors which have been shown by clinical trials to significantly improve progression-free survival, and in the case of recurrent disease, also overall survival. So up above, you'll see the SOLO-1 trial looking at olaparib following first-line chemotherapy for ovarian cancer and showing a significant improvement in progression-free survival. And down below, the PAOLA trial combining olaparib with bevacizumab for high-risk disease, also in the first-line setting, and again showing the addition of olaparib as compared to placebo significantly improved progression-free survival. So with SOLO-1, we're talking about numbers like 56 as compared to 14 months. So that's a huge difference. And with bevacizumab, 37 versus 22 months, numbers here a little lower, probably secondary to a selection of higher risk patients for that trial. A second agent, niraparib, has also been shown in the first line setting to improve progression-free survival in high-risk disease, a similar patient population to the patient population selected for the PAOLA trial. So this includes stage 4 and inoperable patients and patients with macroscopic residual disease following surgery. And again, showing progression-free survival in both in the overall population, in the HRD population, and in HR proficient tumors as well. So unlike olaparib, niraparib is also approved, FDA approved, for the treatment of non-HRD and non-BRCA mutated ovarian cancers. The challenge with all of these treatments is that it requires that we test for BRCA mutations, germline and somatic, and for HRDs, HR deficiencies in the tumors of these patients. Yeah, I'm going to wait for the slides to come up. So that means that during a fairly short interval of time, the time from potentially interval debulking surgery to the end of adjuvant chemotherapy, we might have 2.5 to 3 months in which we have to complete a set of 3 different tests, which could take several weeks in order to determine whether a certain patient might benefit from the addition of PARP inhibitors following their first-line therapy. When they do, we're going to talk a little bit about immunotherapy and its role in gynecological cancers. Immunotherapy in cancer would be based on the premise that the immune system plays a role in cancer surveillance and eradication. And you've heard about that from at least 2 of our speakers earlier. And that cancers with high tumor mutational burdens will present more foreign neoantigens, triggering an immune response. So immune checkpoints do exist in our body to protect against the overactivity of the immune system, like inflammation and autoimmunity. And we can exploit those checkpoints, or malignant cells can, in order to evade the immune system. So inhibition of these checkpoints in cancer cells can encourage an immune response against the cancer. So immunotherapy was trialed in one study, Keynote 158, which was a basket trial with multiple tumor types that were non-colorectal, but included microsatellite unstable or mismatch repair deficient tumors, including, amongst others, endometrial cancers and cervical cancers. All right, I think we're back on track. So we were just talking about the use of immunotherapy in gynecological cancers, and we were talking about Keynote 158, which was a basket trial looking at multiple tumor types, but they were all microsatellite unstable or mismatch repair deficient, and that included a large number of endometrial cancers, so 49 out of the 233 patients in Keynote 158. And you can see at the top line that endometrial cancer patients had a significant overall response rate of 57%, and also a prolonged response duration for those who did respond. So that was very interesting. And Keynote 158 also included a number of cervical cancer patients. And amongst the cervical cancer patients, those who did express PD ligand 1, which were 82 of the cervical cancer patients, showed a response rate of about 15%, and again, a long duration of response. So that first signal was encouraging. And following that, another trial, Keynote 826, was just recently published. And Keynote 826 included almost 550 cervical cancer patients and looked at pembrolizumab versus placebo along with first-line chemotherapy for persistent, recurrent, or metastatic cervical cancer, demonstrating a 22% complete response rate, which is really high, and also very durable response with a median of 18 months of response as compared to 10 months with chemotherapy alone, leading to a significant progression-free and overall survival benefit. Well, how about different combinations? So yeah, in endometrial cancer, pembrolizumab was combined with a VEGF inhibitor called lenvatinib. This shows results from a phase 2 single-arm study looking at this combination in previously treated metastatic endometrial cancer, majority of which were actually microsatellite stable and MMR proficient. And this trial demonstrated an objective response rate overall of 38% and 36% in the microsatellite stable cohort. And what was even more interesting was that the response rates were even higher. Sorry, the slide isn't that clear, but the response rates were even higher, 50 to 80% in the non-endometrioid cancers, including serous and clear cell. And that the duration of response was also very impressive amongst those responding, with a median of 14 months. So those are all really interesting results. Following this, Keynote 775 was just recently presented, and that included over 800 patients with advanced endometrial cancer progressing on prior platinum-based chemotherapy, and it compared the combination of pembrolizumab and lenvatinib with investigators' choice chemotherapy, either doxorubicin or paclitaxel, and showed that pembro-lenvimo was associated with better response rates, 32% versus 15%, and an improved progression-free and overall survival, even in the MMR proficient or MS stable population. This combination has been approved by the FDA, by Health Canada, by the Australian Therapeutic Goods Administration, and just recently by the EU as well, and can be offered to endometrial cancer patients really across the board. Now, what's interesting is that in order to target all these therapies to the appropriate patients, what we're going to really need is the diagnostic technologies. Companion diagnostics exist for most of these targeted agents. We've already talked about the challenges in newly diagnosed ovarian cancer, where we need to complete testing in order to be able to target PARP inhibitors to the appropriate patients at the end of first-line chemotherapy. In endometrial cancer, some of these diagnostic companions are not that difficult. So microsatellite instability or MMR testing, those are fairly straightforward. MMR testing can be done by immunohistochemistry and then further stratified by MSI testing, and that's available in most pathology labs. Tumor mutational burden, however, is emerging as a broader diagnostic companion for the selection of patients for immunotherapy. And just in the past few years, the profiling of endometrial cancer is becoming more complex. So in 2013, the Cancer Genome Atlas Network used genomic and molecular profiling to classify endometrial cancer and identify risk groups within the endometrial cancer population that were linked to prognosis, and then eventually also linked to associated benefits for adjuvant treatment strategies. So molecular profiling is highly reproducible, and much more so than H&E histology. This was not widely adopted because there were some worries about cost, about logistics, but recently the PROMIS molecular classification scheme came out as a really pragmatic, applicable, and easily performed diagnostic tool that can be performed on paraffin-embedded tissue. This was developed in Vancouver and is now becoming more and more widely used and is currently being used in a prospective trial called TAPER for de-escalation of adjuvant treatment of endometrial cancers based on their molecular profile. So really interesting stuff. Again, with immunotherapy for cervical cancer, we know that cervical cancer patients who do not express PD-L1 program death ligand 1 will likely not respond to immune therapy. So this needs to be used as a selection criteria for these patients, both in lung cancer and in cervical cancer. We know the expression correlates with the response to immunotherapy. And most PD-L1 tests use immunohistochemistry, but testing methods will vary widely, and the scores vary widely with differing inter-reader concordance. So again, something that needs a lot of work. Emerging tests, I think we all are familiar with cell-free or tumor DNA testing. So blood tests looking at DNA fragments from tumors that are increasingly being looked at. The origin of this technology is in fact non-invasive prenatal diagnosis, or NIPT, and just in the past few years has been used in oncology. So we can theoretically use this for as a screening tool to discover cancers at a really early stage. We can use this for disease monitoring to monitor the response to therapy, and for therapy targeting as well, instead of obtaining a biopsy to look at molecular or genomic profile of cancers. We can do that with these cell-free DNA samples. So I think that's definitely going to be in our near future. A couple of other technologies I'd like to address are remote virtual patient monitoring. So patients undergoing systemic treatment will experience a really high burden of disease symptoms and treatment-associated toxicities. They're going to be increasingly anxious. They're going to have a really high rate of interactions with their healthcare teams. And most care models will focus on these periodic encounters, usually around treatments, where the ideal model would be a continuous patient-reported outcome and systemic monitoring. So this is something we're working on in Sheba. So we're going to be launching a remote virtual patient monitoring platform, looking at a comprehensive program using measurable physical variables like activity levels, turgor, glucose levels, blood pressure, and pulse rates, obviously, as well as patient-reported symptoms and toxicities, and with all the gynecological cancer patients undergoing systemic treatment. And I think this is going to give us a lot more information and make patients feel much better taken care of. And finally, I will just briefly mention that that artificial intelligence will have multiple implementations in oncology. So Sheba is part of a national health tech hub called 8400. Health network incorporating technology companies in the health tech sphere, and then its own innovation hub, ARC. And those are all working on new technologies with multiple implementations in the field of oncology as well as others. So next year, we'll be talking about some new implementations of this. And at this point, I am done and I'm happy to answer any questions. Yeah, so, okay, great questions. So can targeted therapy be offered as a first-line option? So I think certainly, it would depend on which disease site, but I think, 826, looking at immune therapy along with chemotherapy as first-line systemic treatment for cervical cancer has shown us that this is a useful treatment, and that, it's something that we should consider for all of these patients. I think with endometrial cancer, we're not quite there yet, but I believe that immune therapy or perhaps combination therapy might become first-line treatment for these patients in the next few years. And with ovarian cancer, we are already there. So we're using PARP inhibitors for maintenance treatment following first-line chemotherapy. I don't know that PARP inhibitors will replace chemotherapy in the near future, but that certainly might be the case later on. Other questions? Any phase 3 trials offered to foreign citizens? Absolutely. So all of our trials are open to both Israeli citizens and foreign citizens. There's no selection. So any trial that's open here, and we have multiple phase 2 and 3 trials open in gynecology, and they are all open to international patients as well. Okay, thank you very much. It was a pleasure to be here, and we'll be happy to see you at the next REACT conference.